second. So yesterday we dealt with filtration. Today I'd like to talk about transport mechanisms. And you remember that massive carboy I brought in that showed you about 2 hours worth of filtration? Well, guess what? That's also 2 hours of reabsorption, because 99% of most things are reabsorbed. So we've got to do a lot of work to reabsorb that stuff. Now, it is true that the oncotic pressure kind of helps us to reabsorb some of that. Remember, in the peritubular capillary, the oncotic pressure is such that it favors reabsorption. But we've also got to reabsorb a lot of solutes, sodium and potassium and glucose and everything else. And that all requires extra energy. Okay? So, and that's the processes we'll go through today. So, 2 halves. The first hour is going to be about 70 minutes long, and the second hour is going to be 40 minutes long. Okay? Have I confused anybody yet? No, good. I also have on that first page, I'm changing the sequence around a little bit from Costanzo because I think it works better. If you get confused and you don't know where to go to Costanzo to back up, there's a whole list there of things that we're covering and the order we're covering them in. So let's start with a case. A 33-year-old man has chronic renal failure. Oh, chronic kidney disease, sorry. This is an older case, so that's using older terminology. As a result of polycystic kidney disease. The patient's father and sister? I can't read, I need my glasses. Sister? Okay. Also have the disease. The patient feels well and is employed as a mechanic. Physical exam reveals a blood pressure of 170/95, which tends to happen in this type of disease with bilateral large palpable kidneys. So there's the blood work. Creatinine is 7.2. Now, we haven't done creatinine yet, but I think most of you are aware that it kind of indicates glomerular filtration rate. And at that high level, his glomerular filtration rate is abysmally low. And we'll just leave it at that for right now. So, presumably, kidney failure has some effect on reabsorption mechanisms and secretion mechanisms. So he's got bad kidney, or bad kidneys. Oops. So, what sort of trouble does he have? All right, let me start with sodium. Gosh, the sodium's 140. It's okay. Is that kind of what you'd expect? So let me lead you down the garden path here a little bit. So sodium's the major extracellular ion, right? So it would seem to me that if the kidneys have got problems, then maybe the sodium would be most affected, right? It kind of makes sense until you start to think about it. Well, do you have trouble reabsorbing sodium? Not really an issue, because remember, if the filtration is less than 10%, then you've not filtered much sodium in the first place, and so it's not an issue properly reabsorbing it. Does that make sense? Okay, so no problem with the sodium. What's next? Oh, CO2, and I'm using old nomenclature here. CO2, read bicarbonate. It's not really CO2. It's called CO2 in these old-fashioned blood works because you basically just add acid to the blood and see how much CO2 comes off. And that would be indicative mostly of bicarbonate. Okay? But the bicarbonate is low. And again, we're going to spend 2 or 3 hours on this towards the end of next week. But a low bicarbonate is generally indicative of an acidosis. Okay, so I'm going to cheat a little bit. So we have trouble with hydrogen ion. Next, calcium. Well, it's a little bit low. Calcium can be quite variable, and let me not spend a lot of time on that right now, but it's related to vitamin D. What about potassium? Looks like we got trouble with potassium. What about phosphate? Looks like we got trouble with phosphate. So, most things that are reabsorbed, not a problem. But things like hydrogen ion, potassium, and phosphate tend to be taken in excess, and so the normal kidney doesn't have any problem getting rid of those things. But bad kidneys with very little glomerular filtration they have trouble getting rid of those substances. In other words, in order to excrete enough of something, you got to have a reasonable amount of glomerular filtration. So in some cases, it's a secretion problem. For hydrogen ion and potassium, we actually need to secrete those things. That's the opposite of reabsorption. Okay? And so with very little glomerular filtration rate, we don't have enough secretion to wash out, well, we don't have enough glomerular filtration rate to wash out those secretions. So what about glucose? No problem with glucose. Okay? So normally we reabsorb glucose. We want to reabsorb as much glucose as we possibly can. The filtration rate goes down, so that's less that we have to reabsorb. So that's kind of a scenario for renal failure. Yes, ma'am.
Dr. Rowe, I have a question regarding the level of CO2. So if a patient who has a low CO2, the problem is secretion problem of the hydrogen?
So the question is, how does a low bicarbonate relate to hydrogen ion? We are going to spend 2 or 3 hours dealing with the relationship between acid and bicarbonate. And so let me just leave it for right now empirically that a low bicarbonate is a reflection of an acidosis. In other words, too much acid on board. Too much acid on board because we can't get rid of the acid by the kidneys. Okay? So what I would like to do is start, make sure I haven't missed anything out. Okay. Let me start by just generally looking at the kidney and what happens. I'm going to start with the fluid. So if we have fluid is filtered, and let's say 100% of it arrives here in Bowman's space, by the time we get to the end of the proximal tubule, about 36% remains. So in other words, about 2/3 of the fluid has been reabsorbed in the proximal tubule. The proximal tubule is kind of the workhorse of the system. It does a lot. By the time you get to the bottom of this loop, you got about 20% remaining. So presumably, that means more fluid is reabsorbed in the descending loop of Henle. Is the terminology good for you guys? Okay, good. When you go through the ascending loop, you've got 20% that remains at that point. So, so nothing happens in the, don't write this down, I'm being provocative, nothing happens in the ascending loop of Henle, right? Obviously I'm lying. We know that stuff happens. However, there is little to no fluid reabsorption in the ascending loop of Henle. There's a lot else going on, but little fluid reabsorption. And then by the time you get to urine, you got about 1% remaining. Okay? So that's just the fluid, the bulk fluid. So in general terms, most of the work's done in the proximal tubule. Some things are regulated there, and some things are regulated in the distal tubule. But the distal tubule is basically the fine-tuning. I made a comment that 99% of most things are reabsorbed. And let's just work on the exception. So 99% reabsorbed. And that's true of water, that's true of sodium, that's true of chloride, that's true of a lot of things, of glucose. There are some exceptions. Potassium is somewhere around 85, 86% reabsorbed. Phosphate, also about 85% reabsorbed. And urea, about 50% reabsorbed. So what this means is, let's just take the potassium and the phosphate. We actually have or take on a lot of potassium, and we take on a lot of phosphate, and so we don't usually need to reabsorb it all. We take in a lot of phosphate, a lot of potassium, and so we tend to get rid of some of it in the urine, about 15%. Under normal circumstances. So we don't need to reabsorb 100%. And so we actually have mechanisms, we actually have to be sure that we excrete the appropriate amount of these two substances. Urea at 50%, we're going to talk a lot more about urea later, but I just wanted to highlight those things as exceptions to the rule. Oh, secretion. Like I said, most things are reabsorbed. Let's use a different color. Okay. So, secretion, which would be movement from the blood into the tubule, would include hydrogen ion, a lot of organic compounds, and potassium, and also hydrogen ion secretion. So most things are reabsorbed, but these are the notable things that are secreted also. Okay. Any questions on that? Okay, below that diagram, I've just noted the diuretics. You'll do this more in pharmacology later, but there are diuretics that work at different points in this nephron. All the diuretics I'm going to talk about inhibit sodium reabsorption. Okay. First, the carbonic anhydrase inhibitors inhibit sodium reabsorption. And if you give these therapeutically, it's not usually just as a diuretic. There are usually other things going on. And because they're called carbonic anhydrase inhibitors, you probably guess that they're tied to acid-base balance. So carbonic anhydrase inhibitors. Loop diuretics, which are very potent, furosemide, ethacrynic acid, bumetanide. Okay. And then you have thiazides that work in the early distal tubule. And then finally, you have potassium-sparing diuretics like amiloride and spironolactone that work in the late part of the nephron. Potassium-sparing because their mechanism is tied to potassium secretion. We will go through that more later. Don't worry if that doesn't come together for you right now. It'll come together for you later. Okay? So that's where all the diuretics, classes of diuretics work. And at the bottom of the page, I've got a list of primary active transporters. So there aren't really a lot of primary active transporters. Most transport is secondary active transport. Okay? In other words, generally, probably the one that you'll know the most about is the sodium potassium ATPase. And we're going to talk about that as we go along. The sodium potassium ATPase is a high energy pump, and if the secondary active transporters can tie into that, they basically work by actively moving things with the help of that sodium potassium ATPase. And that will become clear in the next diagram that I put up. Well, I hope it'll become clear. Okay. Now, I'm a little strange. There's a whole bunch of diagrams in the next few pages of cells, and we're going to start in the proximal tubule and look at what happens there. We're going to go to the late proximal tubule and look what happens there. Then we're going to go to the loop of Henle and look at the cells there, and distal, and so on. So, and I get really excited about these diagrams. I suspect that you guys as medical students will say, gosh, Rowe, this is just more detail that we got to remember. But I don't think it's too terribly bad. You may disagree with me. So let's start with the diagram that we have on page 4. Brush border membrane. So this is the luminal side, and this is the blood side. Okay, so as you know, all cells have a sodium potassium ATPase. And as I said before, this is an engine. I mean, it really moves stuff with high energy. Okay, so that's the primary active transporter. And then you'll see on the left side of the diagram, there's a whole bunch of things that are moved by secondary active transport. So, and what's the first one? Sodium and glucose? Yes, sodium glucose. So what's going on here is that glucose is going against its concentration gradient, but it's taking a ride on the sodium. The sodium wants to move this way because you've pumped so much sodium out that your sodium inside the cell is what, about 10 or thereabouts, 10 millimoles per liter? What was the value that you were given? About 10? Can't remember. Okay. It's low. So it's low, and so the sodium is moving into an environment where it's going down its electrochemical gradient. And that's what's driving the glucose. Okay? So I tell you what, since everything depends upon this thing, every time I put a new cell up, if I don't do this first, then take issue with me, because this is always the driver. What's the next one on there? Amino acids, okay. Same principle. There are actually a number of different transporters for amino acids, at least 4. And it depends on whether they're basic, neutral, or acidic amino acids. So so this is basically represent a whole population of different specific amino acid transporters. But just in general terms, there are transporters, and they all use sodium gradient to move amino acids from here into here, okay? And probably the next one, so sodium, probably lactate, sulfate, and a whole bunch of other things. So, and there are specific transporters for all the substances that we want to reabsorb, okay? So, a lot is reabsorbed, again, by sodium co-transport. Lastly, you have an antiporter. The sodium-hydrogen exchange. And you will sometimes see this listed as NHE, sodium-hydrogen exchange. And in the kidney, it's number 3. This actually is the most. This is the transporter that moves the most sodium on the luminal membrane. So there's a lot of this. It moves a lot of sodium, and it exchanges a lot of hydrogen ion in exchange. So in other words, this secondary active transport is a powerful means for getting rid of hydrogen ions. In general, our diets and our metabolism generate a lot of acid, and so we have to have a mechanism of getting rid of hydrogen ions. And we'll talk a lot more about that later. So, any question? Oh, so I've got a note here. There's a whole bunch of things that have to happen on the other membrane, the basolateral membrane. But we know much less about those mechanisms, and in general, I don't think I'm going to trouble you with them. So I've just got a note, let's ignore them. The thing, before we leave this though, I want you to understand that this is a very leaky epithelium. And so some of these things back leak, but it's also very permeable to water. And so the water follows the solutes. And to amplify this, the osmolarity of plasma is 300, the osmolarity of filtrate is 300, and the osmolarity at the end of the proximal tubule is 300 also. So in other words, the proximal tubule's done a lot of work, it's moved a lot of solutes, but it's also proportionally reabsorbed the same amount of water, okay? Hence the concentration, the osmolarity hasn't changed by the end of the proximal tubule. Okay, so I have a question for you. We moved a lot of sodium, and we know that sodium is the major cation in plasma, but what's the major anion in plasma? Chloride, yeah. So, darn. We've done everything but move chloride, yes? So there's got to be some sort of mechanism for catch-up. And so if you flip the page, oh, tell you what, let me cover some other things first. Let me leave you hanging in suspense. Do you feel really? Yeah, okay, let me leave you hanging in suspense and just talk about a few other things first. I got ahead of myself a little bit. So on the next page, page 5, talks about proteins. And remember, we talked about proteins a little earlier, proteins, albumin. Some gets filtered. It's still a very small amount, but whatever gets filtered is reabsorbed. Most of that reabsorption is done by endocytosis. In other words, the proteins are captured, endocytosed, and then they combine with lysosomes to break down into constituent amino acids. Some is also broken down in the brush border membrane. There are peptidases in the brush border membrane that can actually break proteins down, and then you can reabsorb amino acids directly by the mechanisms that we just described. And some of these transporters will actually reabsorb dipeptides and tripeptides as well. So proteins are also reabsorbed. And then what I'm going to do is, you guys are medical students, and the one thing that you do really well is remember everything you're told, right? But there's a limit to what you're capable of doing, isn't there? So part of my job is to decide what not to tell you. And so there is secretion of organic substances here. All right, I've put some diagrams down, but the research in this area is evolving. And what I'm thinking is that you don't need to know the details, because even the textbooks are a little bit fluffy on the details. But what I would like to do is tell you that there are basically two secretory transporters. There's an organic anion secretor, E-R or O-R? O-R, yeah, okay, thank you. And there's a separate organic cation secretor. The utility of this is that any kind of organic substances that come on board can be got rid of in a rather non-specific fashion. So we actually have the capability of secreting a large amount. Some of these organics can be secreted at almost 100% of what's delivered to the kidney. So the secretory mechanisms are very strong. However, you might say, well, are all organics bad? And of course, they're not all bad. So there are mechanisms that help us to reabsorb some of the goodies. I mean, things